Students will be starting with malaria, anti-malarial drugs. As usual, we'll not be discussing too much regarding the life cycle of malarial parasite. I think that have been best explained in parasitology. We'll just fix on or we'll just stick on to the pharmacological perspectives. But again, just a small recap of those names which we have, like what will be secreted from the saliva of the mosquito bodies. Sporozoites will be secreted. Sporozoites will move to the liver. Sporozoites will be converted to Merozoites, and or if energy like mitochondrial ATP synthesis is up to the max, sporozoites can be converted to Hypnozoites. Merozoites, on the other hand, will be released out into the blood. Now we have RBCs. Inside the RBCs, we have Merozoites. More Merozoites will be produced, or if mitochondrial ATP synthesis is up to the max, Merozoites will be converted to Gametocytes that will be stored over there. When the next mosquito comes and bites with you, when it sucks up blood, this Gametocytes will gain entry into the mosquito, because even though our body RBCs are responsible for the synthesis of male and female Gametocytes, that is prohibited to doing sex inside our body. It will not be having any intimation there, but once it gains entry into the mosquito, there the reproduction will tend to occur. That will further produce more sporozoites, which in turn will be released to the next human being. Overall view of what exactly happens whenever a malarial parasite is gaining entry inside the body. The take-home point is we have sporozoites. No drugs are targeting sporozoites, so leave it. We have Merozoites, Hypnozoites, Gametocytes. Three major targets which we have currently as per pharmacology is concerned. So let's talk about RBCs, guys. You remember that inside the RBCs, the Merozoites will be stored. Consider here is where the RBCs are. Inside the RBCs is where your Merozoites. And inside the Merozoites, because these are all just parasites, buddy. So it will not be having any pre-filled or pre-synthesized enzymes. Very minimal amount of enzymes or proteins will be there. It is primarily dependent on the environment. Here the environment itself is RBCs. So it will be having just a big food vacuole will be there inside it. So what are these three different areas? This is your red blood cells, and we have this Merozoites, and we have food vacuoles. These are the food vacuoles. Now what happens, this Merozoites will be taking up hemoglobin from the RBCs into the food vacuole. Even though it is utilizing multiple different mechanisms of energy production, one of the mechanisms is hemoglobin's intake, right? So hemoglobin is going to be taken up inside the Merozoites with the help of a protein called as Kelch protein. With the help of a protein called as Kelch protein. This Kelch protein will be there on the surface of the Merozoites, on the surface of the parasites, responsible for hemoglobin's uptake. Now what happens inside, the hemoglobin will be broken down to globin and heme. Heme and globin it will be producing. Globin will be utilized as a protein source by the Merozoites for further replication and proliferation. But heme, when it is accumulated there, it behaves as a waste product. Just take up a paper and tear it down. No, it is like heme. A lot of hemes will be there. How do you clean the paper bags? You just take up all the paper, put it up inside the dustbin and close that dustbin bag, right? Similarly, these hemes which are actually dispersed are actually toxic to the parasite. These are toxic to the parasite. So what the parasite does, it will take up all the heme, join it together to form an inactive component called as Hemozoin. This Hemozoin is a non-toxic metabolite. As it is taking up heme, multiple heme together and combining it together, this enzyme which is involved here is called as heme polymerase enzyme. The enzyme which is involved for this particular process is called as heme polymerase enzyme. What do you think the mechanism of action of the first-line anti-malarial drug is going to be? You would have guessed it. Yes, chloroquine. What is the mechanism? It will be inhibiting heme polymerase enzymes. So this heme polymerase enzyme will be inhibited by chloroquine, the first-line anti-malarial drug. Not only that, even quinine has got the same mechanism. Lumefantrine, and amodiaquine. All of these four drugs will be having a very similar mechanism of action. It will be inhibiting the heme polymerase enzymes By inhibition of heme polymerase enzymes, more toxic heme will be accumulated, which in turn will land up in breakdown of the parasites. The second one, of course, as I was talking multiple times regarding mitochondrial ATP synthesis, which means we are going to be designing certain drugs which is targeting those mitochondria. I hope you are there with me till now. So here inside there will be certain mitochondria, guys. We have the mitochondria, which is responsible for the ATP synthesis, and this mitochondria is getting inhibited by Primaquine. And one more newer drug is there called as Tafenoquine. Primaquine and Tafenoquine, two drugs which tend to inhibit the mitochondrial ATP synthesis. And I've given you a clue before itself, my dears. I told you that if mitochondrial ATP synthesis is very much high, or if the mitochondrial ATP synthesis is at the max, the sporozoites can be converted to hypnozoites and merozoites can be converted to gametocytes. Which means for synthesis of hypnozoites, for synthesis of gametocytes, we need more amount of ATP synthesis. Well, that is getting inhibited by Primaquine and Tafenoquine, which means simply these drugs will be breaking down the hypnozoites. Will be breaking down the hypnozoites and it will be breaking down the gametocytes. Whereas this chloroquine, amodiaquine, quinine will be primarily breaking down the merozoites, because which are there on the blood vessel inside the RBCs. That's why it is primarily acting up into the erythrocytic stage of the parasite, right? Whereas hypnozoites are going to be there on the pre-erythrocytic stage. We'll discuss more about that later. Now we have one more drug called as Artemisinin derivatives. We have one more drug called as Artemisinin derivatives. Here comes the Chinese product, no? Artemisinin derivatives. This will induce free radical damage. This will induce free radical damage. So what do we expect the mechanism of action of this artemisinin derivative is going to be? It is inducing free radicals, not immediately, my dears. It will release out free radical, thereby induces a radical damage to the plasmodial cell membrane. How it is actually producing is a beautiful concept. This artemisinin derivative will be taken into these molecules. It will be taken into this parasite in the presence of heme, which will be there inside the parasites. This artemisinin will be activated. Once this artemisinin is getting activated, that will release free radicals, which in turn will produce damage to the membranes. As simple as that. So artemisinin derivatives will be uptook into the parasites. It binds with heme, thereby tend to get activated, and thereby it is getting activated. Please note this is an important step in the mechanism of artemisinin derivative. Also, we'll be explaining more regarding the resistance patterns of artemisinin derivative here itself. So what exactly do you think the resistance of artemisinin derivative is going to be, buddy? Artemisinin is gaining entry into that, and now how it is getting activated when it is binding with the heme. What if the hemoglobin uptake itself is not happening there? What if the parasite is surviving with other sources of energy? It is not dependent on hemoglobin as a source of energy. Then this artemisinin derivative will not be functioning. So the mechanism of how the resistance will be developed, mechanism of resistance development is a mutation in the Kelch protein. This Kelch protein is nothing but K13 protein, which is developed especially in Plasmodium falciparum. That's why its name is Plasmodium falciparum K13 protein. Plasmodium falciparum K13 protein, which is Kelch protein, guys. If a mutation is happening in this PFK13 protein, there will be a resistance development against artemisinin derivative. Similarly, we'll move to the chloroquine, guys. What is the mechanism of action of chloroquine? Chloroquine is gaining entry inside this parasite, binding with heme polymerase and tend to inhibit it. So what if what if the parasite designs a particular transporter and which is getting incorporated on the cellular membrane itself? And this is responsible for efflux of chloroquine. Chloroquine gains entry and it is going to be thrown out of it. This mechanism is called as efflux pump, and that is explained as the mechanism of resistance development against chloroquine body. And the name of this efflux pump is called as Plasmodium falciparum chloroquine resistance transporter. That's it. Plasmodium falciparum chloroquine resistance transporter. So we have two different types of how resistance would be developed. First one is PFCRT, Plasmodium falciparum chloroquine resistance transporter, which is for chloroquine. That is an efflux pump, my dears. This is an efflux pump by which the chloroquine is getting thrown out from the body. The second one is regarding Kelch protein, right? This is PFK13 protein. If there is any mutation in it, the artemisinin derivative will not get activated. Thereby, it will prevent the hemoglobin from gaining entry into the cells. As simple as that. Here is where the Kelch protein is. We have already explained about the pharmacological or physiological use of this Kelch protein. These are the three major set of drugs, which includes the basic drugs like chloroquine, quinine, and we have explained about primaquine, tafenoquine, also the artemisinin derivative, artemisinin drugs, and what is its mechanism. We have explained about the resistance patterns too. Now, let's move on further. Let's talk about what is the treatment for causal prophylaxis. Simple one. Causal prophylaxis, any drug, any species which we take, Primaquine will be the treatment of choice. No worry, don't worry about this. That's why questions will not be asked from the causal prophylaxis. What will be the treatment for suppressive prophylaxis? This is an important question. Suppressive prophylaxis means if you are planning to travel to an endemic area, before exposure of that, before going towards that area, you have to start the therapy with some drugs, and after return from that, you have to continue the therapy. Just understand that 2 doses has to be administered before the travel, 4 doses has to be administered after return from the travel, and during the travel, you have to take the tablet also. Or for how long you are staying in that particular country, you have to take that tablet also. We have 2 drugs under that. The first one is mefloquine, the other one is doxycycline. Mefloquine has got a long duration of action, guys, whereas doxycycline has comparatively a shorter duration of action. That's why mefloquine is administered 2 weeks prior as weekly doses. Every week 1 dose has to be given, and 4 weeks after return from the travel, 4 weeks we have to take up mefloquine weekly 1 doses. Whereas doxycycline 2 days prior to the travel, daily once you have to take for 2 days, and after return we have to take as a daily dose for the next 4 weeks. Now, one important point is there, guys. If you are planning to travel to Thailand, which of these drugs has to be taken? You might travel to Thailand for any reasons. Might be some educational reasons, or from conferences you might go. Don't think that every time you're going to Thailand only for one particular reason. No, you might go for multiple reasons. So when you go to Thailand for some educational purposes or from conference purposes, before that you have to get that prophylactic therapy, and that patient should be under therapy with the doxycycline. Doxycycline has to be given. What if you are planning to go to Caribbean islands? Again for conferences, any concepts which you take. There, the prophylactic therapy, suppressive prophylaxis, should be chloroquine itself. 500 mg is administered as weekly drug doses. Chloroquine has been given for Caribbean islands if you are visiting there, because their chloroquine is highly sensitive even for suppressive prophylaxis too. So for Caribbean islands, if you are traveling, chloroquine 500 mg has to be administered on weekly doses. Any other countries if you visit, we have to go with mefloquine. Mefloquine for any other countries when you plan to visit. Especially I'm talking about endemic areas. Now please note that this mefloquine, which we have written over here, might be producing neurotoxicity and seizures, very much high. Mefloquine will be producing CNS toxicity. Remember, with this mnemonic, mefloquine will be producing mental changes or mental adverse effects. Mefloquine will be producing mental adverse effects, a basic concept to remember. Also, we have multiple other drugs, guys, like psychoserin is there. Psychoserin, we change the name psychoserin. Why? Because it might produce neuropsychiatric disturbances. Similarly, mefloquine also is associated with the neurotoxicity. Tetracyclines, we have discussed that. Kapil Dev's BAT, a mnemonic for that, which means BAT is for bone and teeth deformities, my dears. which means these drugs are again contraindicated in pregnancy and in children less than 8 years of age because it might lead on to bone and teeth deformities and developmental abnormalities. That's it about suppressive prophylaxis. When you're planning to travel to an endemic region, all the classical features we have explained. Now let's talk about in India, if you have if you are caught up with malaria, how to treat malaria. Here in India, the primary treatment currently which we use is artemisinin based combination therapy. Yes, it is not RT, it is RT. Okay, artemisinin based combination therapy. We have multiple different drugs to be given in this list. The first one is Artesunate with mefloquine, Artesunate with amodiaquine, Artesunate with sulfadoxine pyrimethamine combination, dihydroartemisinin with piperaquine, artemether with lumefantrine. Don't worry, no one will be asking you what exactly out of this, which is the combination used for artemisinin-based combination therapy. They will not ask it. But they will be asking, why do we give it in combination therapy? Why can't we administer artemisinin as monotherapy? You can administer artesunate as monotherapy, no, but we don't usually administer it. The need for a combination therapy, two reasons are there. The first one is to prevent development of resistance patterns. As I told, Kelch protein resistance, to prevent the development of resistance, we have to administer it in combination with one another drug. Also, artemisinin therapies tend to have a shorter duration of action. So when you give it along with one more drug which tend to have a longer duration, the overall duration of action is going to be prolonged. Two reasons why we have designed something called as artemisinin-based combination therapy. One is to prevent the development of resistance. The other one is longer duration of action. And out of all these combinations, we have this sulfadoxine pyrimethamine, which is not effective against Plasmodium vivax. And the last one, we have artemether lumefantrine, which is effective in northeastern parts of India. It can also be administered in other parts of India too. This is the advantages of artemisinin-based combination therapy, guys, right? Some classical features of these points also. Now let's talk about treatment of uncomplicated malaria. How do we proceed further? Uncomplicated malaria in India, if you catch hold of it, see, there are multiple different subtypes of like Plasmodium species, like Plasmodium vivax, Plasmodium ovale, Plasmodium falciparum, Plasmodium malariae, and one more thing, most of the people will not be knowing it. That's why it is called as no lessee, right? No lessee. The multiple different subtypes are there. But be it any subtype, as per pharmacology, we are classifying it into only two major subtypes. Either it is chloroquine resistant or it is chloroquine sensitive. Only two major subtypes are there as treatment is concerned. So we have to administer chloroquine, guys. That would be the treatment of choice. But if it is sensitive, we can go for it. If it is sensitive, we can administer chloroquine for 3 days. Or if it is resistant, we have two major subtypes in treatment. Either we can go for artemisinin-based combination therapy for 3 days, or we can opt for a drug combination which includes quinine with clindamycin or doxycycline, Q plus C or Q plus D, which is given for 3 days again. So we have two drug combinations to be given if a patient is resistant or if a Plasmodium species is resistant to chloroquine. One is artemisinin-based combination therapy, the other one is quinine with clindamycin or doxycycline. Now, let's look into the same concept, whether we have to continue Primaquine. Most of you would have the knowledge from your microbiology, parasitology itself, my dears, because Plasmodium falciparum will not be having any Hypnozoites. There will be only Merozoites, there will be Gametocytes, Hypnozoites will not be there. So Primaquine is a drug, as we have explained previously, is not a drug which will break down only Hypnozoites, it will also break down Gametocytes. Please note that this artemisinin-based combination therapy is there, no? All of these drugs are poor gametocidal agents. All of these drugs are very poor gametocidal agents. The gametocytes will not be killed up in a very much better way with your artemisinin-based combination therapy. That's why it will warrant to add Primaquine along with the regular therapies. Good. So what will be the treatment, guys? We have to add Primaquine, be it any kind of a species. If it is Plasmodium falciparum, I have to administer Primaquine, or if it is a non-Falciparum malariae, even if it is a non-Falciparum malariae, I have to administer Primaquine. but the number of days of administration of Primaquine will be different. Because for non-Falciparum malariae, I have to kill out both the Hypnozoites and the Gametocytes. So I have to give it for 14 days as a daily dose. Whereas for a Falciparum malariae, there is no need to administer it for 14 days. Just give one single dose. That would be enough. Because as I've told already, here it is purely having a gametocidal property. Whereas here, it will be having gametocidal property. And also one more thing, what is that? Killing of Hypnozoites, we officially call it as radical cure. Radical cure means killing of the Hypnozoites. Let's move on further. We have discussed about how to normally treat a patient, an adult patient who is diagnosed with malaria. First, we have to treat with chloroquine. If it is sensitive, chloroquine for 3 days, Primaquine. If it is resistant, Artemisinin-based combination therapy for 3 days and Primaquine, or quinine with clindamycin doxycycline with the Primaquine. Be it any drug, we have to administer Primaquine. If it is Falciparum, single dose, non-Falciparum, 14 days. Now, what if uncomplicated malaria in terms of pregnancy? How do we manage it? Uncomplicated malaria in terms of pregnancy. Pregnant individuals, whether we are diagnosing the patient at first trimester or second and third trimester. We have an important concept here because Artemisinin-based combination therapies are contraindicated in first trimester of pregnancy. I'm talking about here uncomplicated malaria, OP-based therapy. So if it is first trimester of pregnancy, we have to look whether this patient is suffering from a malaria which is chloroquine sensitive. If it is chloroquine sensitive, we can administer chloroquine for 3 days. But if that patient is suffering from a chloroquine resistant malaria during the first trimester of pregnancy, quinine with clindamycin has to be administered for 3 days, because quinine and clindamycin, both of these drugs are the ones which can be safely administered during pregnancy. We have discussed that already under antibiotic general considerations, drugs which are safer in pregnancy. We have discussed about all the drugs, listed all the drugs together with the mnemonic. Now, what if the patient is suffering from the same type of malaria in the second or third trimester? Again, if the patient is suffering from a chloroquine sensitive malaria, same, we can go with chloroquine for 3 days. But if it is chloroquine resistant, here we have no bounds, guys. We can go for Artemisinin-based combination therapy for 3 days. That can be done because there is no contraindications for giving Artemisinin-based combination therapy during second or third trimester. But you should not administer Primaquine because Primaquines might induce a hemolytic anemia in GCSPD deficient individuals. Patients who are pregnant, we might know it, but what about the children? We wouldn't know whether the baby over there inside are GCSPD deficient or not. So because of unknown cases, usually we will not administer the Primaquine during those phases. We will wait till labor. Once the delivery has happened, we will wait till 1 month. And after 1 month, we will administer Primaquine either for 1 day or 14 days based on the type of malaria which the patient have already been suffering from. This is how the treatment process will be happening in terms of uncomplicated malaria. Now, as I've told, here we are talking about GCSPD deficient individuals. You remember that? So we'll just write it up. Primaquine is contraindicated in G6PD deficient individuals. So how do we narrow it down, my dears? How do we find out whether the patient is G6PD deficient or not? By looking at the face, I cannot do that. It's practically impossible. So we'll be having a separate classification of how to give a dose of Primaquine for some patients. If we don't know the GCSPD levels, of what if we have known the GCSPD levels, how to administer the drug dose of Primaquine. So Primaquine can be administered in 2 different cases. In patients who have unknown G6PD levels and known G6PD levels. Unknown G6PD levels and known G6PD levels, usually it is recommended to go for a G6PD kit. G6PD kit assay has to be done even before you administer Primaquine. If it is available, always recommended. If it is unknown, what can be done? Okay, we don't know whether the patient is GCSPD deficient or not. We can administer Primaquine, but how can we administer? The dose is 0.25 milligrams per kilogram per day, which is given for 14 days. As simple as that. 0.25 milligrams per kilograms. If the patient is around 50 milligrams, we have to multiply it by 0.25 milligram. That's the dose which we give. Now, if the GCSPD levels, we have the GCSPD kit and we go for the GCSPD kit assay and we know the levels of GCSPD in the patient. What if the patient is very much deficient in G6PD, right? Then it's going to be less than 30% levels of G6PD. If the levels are very much low, around less than 30% of it, then we can give Primaquine 0.75 milligrams per kilogram per week. That's the difference here. You might be having, oh my god, how am I give 0.75 milligram if patient is deficient to GCSPD? Here we are administering it as a weekly dose, not a daily dose. It has to be administered for a period of 8 weeks. That is the drug dose which we administer when the GCSPD level is very much low, less than 30%. Okay, sir, we have known now it is not less than 30%, it is more than 30%. Now what should I do? I can go for higher doses of Primaquine, which means around 0.5 milligram can be administered per kilogram per day for 14 days. See, the dose of Primaquine which we give for unknown cases is actually lesser than more than 30% GCSPD levels. So it is always recommended to go for a GCSPD kit assay. But sir, we have a newer drug buddy which is actually a derivative of Primaquine called as Tafenoquine. It has got a longer duration of action, but it produces very severe hemolytic anemia in GCSPD deficient individuals as compared to Primaquine. So we don't usually prefer to give Tafenoquine in patients who are having a little bit better level of GCSPD. We have to go with the very much higher level of GCSPD to start the patient on Tafenoquine. Well, that's the third treatment process here. The third point is if it is more than 70%, point number one, and the age of the patient is more than 16 years of age. If the GCSPD level is more than 70% or if the age is more than 16 years of age, then we can administer Tafenoquine 300 milligram as a single dose. We can administer Tafenoquine 300 milligram as single dose. For malaria, the treatment process, the doses are extremely important, buddy. Good. So we have completed about the treatment process for Falciparum malaria and also for non-Falciparum malaria. Uncomplicated, if it is a normal adult, if it is a pregnant individual, if it is GCSPD known, GCSPD unknown, we have discussed about multiple different points. Now we'll move on to the next concept, which is complicated malaria or cerebral malaria. What if a patient is suffering from cerebral malaria or complicated? Here we have to treat it as an utmost emergency because we might lose the patient in few minutes. Patients might be landing up in altered sensorium, hallucinations. In those conditions, we have to admit the patient and we have to administer intravenous Artesunate. In a normal adult who is suffering from cerebral malaria, we have to administer IV Artesunate and we have to administer it continuously for 24 hours. After administering it continuously for 24 hours, we have to change the patient to per oral Artemisinin-based combination therapy. Please note, we can administer any Artemisinin-based combination therapy, the list one which I have discussed about previously, except one combination. We cannot administer a Mefloquine combination. In that list which we have written, the first combination is Artesunate with the Mefloquine combination because Mefloquine produces mental status changes. This itself produces neurotoxicity and seizures. That's why this combination should not be given in terms of cerebral malaria. Okay, sir, this is for adults. Good. A normal adult who is landing up in cerebral malaria. What about pregnancy? What if a patient is pregnant? We have to administer the same drug dose which we have written again. Why? Because our cerebral malaria is an utmost emergency, my dears. We cannot risk the patient by administering any of the usual drugs. We have a backup drug. We have a backup drug which is Quinine with clindamycin. We have a backup drug Quinine with clindamycin. Quinine can be given via IV route. We have a backup drug. But the primary drug which we have to choose is going to be Artesunate via IV route. Quinine might be associated with severe hypoglycemia. So please remember that when you plan to give Quinine for the patient, we have to mix it up with the dextrose solution to prevent the hypoglycemia from happening in terms of pregnant individuals. So we have discussed all these points regarding malaria, uncomplicated malaria, adult, pregnant, complicated malaria, adult, pregnant, and regarding the GCS-PD kit, right? Regarding what dose of Primaquine has to be given for every individual cases. Now we'll move on further. Let's look into that individual drug study. Let's talk about individual drugs. Out of all the individual drugs, the most important one is chloroquine. What are the adverse effects of chloroquine? Please remember that chloroquine has got a very high volume of distribution. Volume of distribution high means you remember that it has got more tissue protein binding and less plasma protein binding. More of the drug will be there inside the tissues. In which tissues it is going to be distributed more? It follows something called a selective distribution. More of the drug will be selectively distributed towards your eyes, and that's why patients will be having something called as, consider here is where your retina is, and there will be bull's-eye maculopathy. This is explained as bull's-eye maculopathy because this drug is getting exposed of, is getting distributed to the vitreous humor. These patients, these drugs might be landing up in bull's-eye maculopathy, one important adverse effect. The next one, it produces very severe nausea, vomiting. Defaultly nowadays, chloroquine, if you get, it will be defaultly added with an antiemetic agent to prevent the vomiting from occurring. Patients might land up in graying of hair. Graying of hair. If you are thinking like, oh my god, I am having a gray hair, might be because I took chloroquine for 3 days, no, during when I was doing my first year time or during my school times. That's not the reason, my dears. Taking like 2 or 3 days of doses will not produce graying of hair, especially chloroquine. Not only that, even we have hydroxychloroquine. These drugs are being approved for rheumatoid arthritis. When it is used for a longer duration of time, patients might develop graying of hair. But the take-home point or the important one for the exams is, what are the different uses of chloroquine? Apart from malaria, multiple different uses are there. All of these uses can be remembered with the mnemonic Rest in Peace MLA. RIP MLA is the mnemonic. R is for rheumatoid arthritis, which we have explained just before a few minutes. Chloroquine and hydroxychloroquine can be given. I is for infectious mononucleosis. I is for infectious mononucleosis. P is for photogenic reactions. Photogenic reactions, which is a variant of Porphyria cutanea tarda. M is for, we all know that. If you don't know this, please go wash your face and sit down and come back, because that's what this topic is actually. L is for lupus erythematosus, systemic lupus erythematosus or drug-induced lupus erythematosus, we have L. And A stands for amoebiasis. What type of amoebiasis? Systemic amoebiasis, not for luminal amoebiasis. See, amoebal infections might be happening in the blood, or amoebal cyst turnover might be trapped inside your intestines. So we have to kill off both, which are there inside the intestines and inside the blood. That's why we prefer to give metronidazole or onidazole. But here, your chloroquine will be having purely systemic amoebicidal agent. It will not be killing off any of the cyst turnover which is present inside the intestines. Well, that's it about anti-malarial drugs, guys. Thanks so much.